Audio recording for this meeting has begun.
All right, we're going to go ahead and get started. Thank you everyone who's joined today. We're really excited to be hosting the It's Confidential Lessons for Massachusetts EOB bill today. My name is Taryn Kucher, and I'm the Senior Manager for Policy and Government Relations at the National Coalition of STD Directors. And we've heard from quite a few of our members that the issue of explanation of benefits and its impact on patient confidentiality is really important, particularly in getting people in for getting screened and tested for STDs. And so we reached out to some folks at Massachusetts who recently passed an EOB bill around confidentiality to get some better understanding of how they passed that. So we're very excited, and we're excited to have you all here today. Just a quick overview of some of the logistics. So as you heard, this webinar is being recorded, and the recording will be made available within 1 week of this presentation. We've muted all the lines to limit background except for those who are the presenters. And there will be an opportunity at the end to unmute specific lines for questions. So if you have questions or need technical help during this call, please utilize the chat function in the bottom right corner of your screen. And you can also send a private message to my colleague, Leandra Lacey, who's listed under the host tab to the right of your screen. And all questions will be addressed at the end, but we will keep a queue, so please send them as your questions begin to come up. For this webinar, we expect that by the end you'll be able to describe the process that Massachusetts took to implementing the patch bill and identify steps for implementing an EOB bill within your own state. And at the end of this webinar, there's going to be a link for reviewing the webinar itself within SurveyMonkey, and we'd love to get your feedback. It'll really help us when thinking through next and future webinars that we want to be implementing. So without further ado, I'm going to introduce our speakers for today. So we've been joined by Dr. Kimberly Daly and Alyssa Evangelii. Dr. Kimberly Daly is the Associate Director of Counseling and Health Services at Salem State University in Salem, Massachusetts. She has more than a decade of experience working with adolescent and young adult populations in the area of health promotion and health education, and her clinical passions include reproductive health care and women's health. She has a strong interest in quality improvement initiatives to improve health outcomes and processes, and she's a strong advocate for patient rights and has participated in several statewide committees and coalitions to ensure access to confidential health care and eliminating disparities. Alyssa Evangelii is the Associate Director of Policy and Government Relations at Healthcare for All, and she leads Healthcare for All's policy and advocacy work focused on payment and delivery system transformation, private insurance, and prescription drug reform. Prior to joining HCFA, Alyssa worked as a legal fellow at Health Law Advocates, where she represented low-income clients experiencing difficulty addressing health care. She earned a joint degree in law from Northeastern University School of Law and a master's in public health from Tufts School of Medicine. Prior to law school, she worked for a number of years in the fields of reproductive health advocacy at Pathfinder International and immigrant health advocacy at Healthcare for All. So without further ado, Kim and Alyssa, I turn it over to you.
Great, thank you so much for that introduction. This is Alyssa Evangelii. I'm going to get started, and just so folks know, Kim and I are going to be kind of tag teaming this, going back and forth between the slides. So hopefully we can keep track of who's doing what. And again, we welcome questions at the end. So just to get started, a little bit of background on Healthcare for All, my organization. We're a nonprofit advocacy organization that promotes health justice in Massachusetts by working to reduce disparities and ensure coverage and access for all. We use direct service, policy development, coalition building, community organizing, public education, and outreach to achieve our mission. I'm going to pass it over to Kim now.
Thanks, Alyssa. And hi, everyone. This is Kim. So we're really excited to have everybody on the call with us today, and we really hope that this is going to be a fruitful conversation and that you are able to gain some of the knowledge that we've achieved up here in Massachusetts. I know this is a challenge, and so hopefully we'll be able to address, some of those issues that you're facing and give you some recommendations that might be helpful for you going forward. So I think it's probably helpful to sort of start with a slight conversation about, what are explanation of benefit summaries, and I'm assuming that since you're on this call, you probably have a pretty good understanding. In some states or in some counties, it's often referred to as a summary of payments, and so, there may be some times where we refer to it as a summary of payment or the SOP. But essentially what the explanation of benefits summary is, it's an intention towards transparency generated by insurance companies to help provide the subscriber of an insurance plan with understanding what services were rendered, what coverages were available based on the policy. It identifies charges, although EOBs or summary of payments are not intended to be a bill. And so I think a lot of times it's actually quite confusing for patients when they get it in the mail because they don't quite understand sometimes what it actually is intended to do. But again, intending that it's a communication plan, it is sent generally from the insurance company after a visit. It details the services provided. It can be both written, it could be electronic. And generally through federal programs, Medicare does provide summary of payments, but most state-based programs actually do not generate payment explanation of benefits or summary of payments for Medicaid plans. And that can vary from state to state, but that is something that I think a lot of us, work with very closely. So next slide.
Great. So I'm going to give just a really brief overview of the federal laws that govern EOBs. This is important to understand as we're thinking about ways that we can build on existing confidentiality protections as well as ways that we can use state law to protect confidentiality. So first is that under federal HIPAA privacy protections, there's an endangerment clause provision. And that provision permits an individual to request that the health insurer communicate protected health information by alternative means or at alternative locations when disclosure of that information would endanger the individual. So that's a good protection, again, that's currently in place in federal law. The problem with that law not being sufficient is that there's no guarantee that the request for the information being communicated in these ways be granted by the health insurer. So someone can make their request, but the health plan is not obligated to comply. Endangerment, the requirement that the person must be experiencing endangerment is a high bar to reach. So we know that certainly there are many circumstances where someone could feel that they could potentially be in danger, but there could be other circumstances where it doesn't reach that high bar and they could not want the information shared for other reasons that would potentially impact their ability to get services in the future or other reasons, which Kim will go into a little bit more when we talk about the problems with existing privacy concerns. And then the third issue is that what we learned through doing some research in Massachusetts is that health plans are not implementing these privacy protections in a consistent way. So sometimes they request that they require that the request be made in person, in writing. Other times they require that it be made over the phone. And so we know that and also the timeframes for complying with these recommendations, or excuse me, timeframes for complying with these requests can vary from health plan to health plan. So sometimes they're able to implement the request within days, other times it takes weeks. So we thought that it was really important to build on these existing protections, but also recognize that they are insufficient. Otherwise, we wouldn't have needed to take steps to improve confidentiality protections. The other federal law is under ERISA. And that provision requires private insurers to provide notice of any, quote, adverse benefit determination, which includes patient cost sharing. So this is important to understand because whenever you access healthcare services, it doesn't have to be an actual denial of a claim. It could be that there's any cost sharing associated, such as a copayment, deductible, or coinsurance, and the private health plan under federal law is required to generate notice to the individual. So as we were thinking about ways to address privacy protections, we had to make sure that any recommendations that we were making for state law changes don't conflict with this federal law requirement. And so I'll talk a little bit about that more later, but to give you some context for the different federal laws that were in place as we went about deciding how to improve confidentiality.
So to talk talk a little bit about, why this is an issue and, kind of the purpose of this entire conversation and probably what many of you are dealing with. So I am a healthcare provider. I am a nurse practitioner. I run a college health center and have been working with university students for the past 10 years. Most of our students are covered under their parents' insurance plan due to the Affordable Care Act, and here in Massachusetts we've had health reform since 2006. So I'm very fortunate in that my students are generally covered with insurance, but unfortunately the explanation of benefits creates the barrier. So as Alyssa had spoken of, protections around HIPAA, as a healthcare provider, I think most healthcare providers are very comfortable with the knowledge of, what HIPAA protections engage. So I think that, we generally feel very comfortable in knowing that the patient-provider encounter is protected. Obviously there are some exceptions outside of HIPAA and protections, but generally that visit itself is very well protected. The piece that, unfortunately, we don't have control over is the explanation of benefit. So after the visit, when the EOB is sent home to the parent or the subscriber, oftentimes it delineates some of those basic services. So it really becomes an unintended consequence, and really breaches the HIPAA protections that were established to really be able to provide patient privacy and the basic right of being able to access confidential services. So who is impacted by this? And I'm sure everyone on the phone can think of at least 5 circumstances. But to try and talk about this, this is really an issue that impacts everyone. And I can say that in the work that I've been doing with Alyssa and Healthcare for All and the Coalition, I've even come to realize impacts on how the EOB has, really created problems for patients of all ages and all sex. Given that, my work has really been working with adolescents and college students, this was definitely something that I was aware of. But, we also see this in terms of, adults covered under a spousal plan. Obviously, it's a very big issue for minors or even college students who are generally covered under a parent plan. And so certainly, there's issues around accessing services, and each state has their own protections about what kind of services minors can access. In Massachusetts, we have something called the mature minor regulations that do allow for minors or those under 18 to be able to access certain services. But again, the concern being that if they're carried under a parent insurance plan and the explanation of benefit goes home, those protections aren't necessarily considered to be confidential or private. So when we think about the repercussions of, what happens when a patient is trying to seek services and those protections are breached, it's been, again, a very fascinating process for me to be involved in this coalition and hearing conversations, outside of the world that, I work in. Certainly for young people, young adults or minors, it oftentimes creates barriers for them to access care. And I see this every single day in my college health center where I have university students that are 18, 19, 25 coming in for mental health services or substance abuse treatment or, certainly family planning and reproductive health. And one of the first questions out of their mouth every single time is, my parents aren't going to know about this, right? And so again, we talk about HIPAA, we talk about privacy, we talk about protections, but unfortunately with the EOB, there's really not a lot of protection that can, provide them that, that sense of comfort in knowing that the visit will be protected. I've also learned that, in working in the emergency room, I was an emergency room nurse in Boston, we would see this very frequently in domestic violence situations. So assuming, if a patient goes to the emergency room or is seeking services for domestic violence or partner violence, it may be that the person who is actually abusing them is the person carrying the insurance. So it's certainly going to result in serious privacy concerns if that patient is now actually going to seek services and is actually going to potentially be an additional threat because their abuser is now going to be alerted to them seeking care. What we often see is circumstances where patients will actually defer or delay care. And that has obviously serious health concerns for patients, but it also increases costs. So when we start thinking about, patients not seeking care, and showing up in emergency rooms when it's a catastrophic injury or, a significant infection, there are certainly costs to the public programs that, we do see as well. And another circumstance that I think is also worthy of just mentioning is, and we've had a lot of conversations here in Massachusetts, is around divorce. Oftentimes when couples divorce, it's not uncommon that one partner will carry the insurance of their divorced spouse. And so you can imagine a situation where your divorced partner is getting your explanation of benefit summaries and being able to see what kind of services that you're being provided. We've seen cases of custody disputes that have actually been brought up because of the spouse seeking mental health services and it being used against them in custody cases. So there are serious implications to this, and the repercussions are quite severe.
Great. So before we get into the substance of what exactly we proposed for strengthening protections in Massachusetts, I wanted to spend a few minutes on the advocacy process in Massachusetts and how we really built a coalition to address this issue. So the work started under a women's health coalition that formed actually back in, well, much earlier, but sort of started taking a closer look at this issue back in 2013. Healthcare for All was part of this women's health coalition, and other members included our Department of Public Health, reproductive health providers from across the state, and others who were doing advocacy such as Planned Parenthood and NARAL, Pro-Choice Massachusetts. And the reproductive health providers in the coalition really started raising this issue as a concern, as a barrier that their patients were facing, as Kim just explained. And so we were thinking about in our work, what can we do as a coalition focused on women's health and reproductive health to try to address this. And at the time, Massachusetts had just passed a comprehensive health reform law, which gave our Division of Insurance, which regulates all private health plans in the state, authority to regulate explanation of benefits forms. Now, it's important to note that their authority to regulate these forms did not touch on confidentiality per se, but they were to regulate sort of how the forms are issued and what is included in the form. So we thought that would be a great opportunity to weigh in with the Division of Insurance and advocate that as they're thinking about the process by which these forms are issued and what are contained in these forms, that they should consider requiring health plans to implement stronger confidentiality protections. So this group engaged in a series of listening sessions and feedback sessions with our Division of Insurance and came up with some pretty comprehensive recommendations for how to strengthen confidentiality protections. Ultimately, the Division of Insurance decided that because there was no sort of direct mandate for them to look at confidentiality, this was sort of outside of their scope, but they were certainly open to ongoing conversations, but were hesitant to commit to making a change at that point in regulation, which would put into place the recommendations that we were making to improve confidentiality. So after a number of years engaging the coalition with the Division of Insurance, we made the decision to pivot to a legislative advocacy strategy, while at the same time maintaining our conversations with DOI, the Division of Insurance. So we didn't want to lose that track, but thought it would make sense to pursue a dual track of legislative advocacy. And I think this varies state to state in terms of how easy or difficult it is to pass legislation. But we knew that the legislative route was going to be a little bit more challenging and potentially, a longer process because it takes a long time to move legislation in Massachusetts. We thought it was important to go that route as well. So as we decided to pivot to a legislative strategy, that's when we really broadened the coalition beyond the women's health work, because I think we really started to understand, as Kim talked about, the scope of this problem and the scope of services that are impacted when you're talking about individuals potentially delaying or forgoing care due to concerns about sensitive health information being disclosed. So we formed the PATCH Alliance, which stands for Protecting Access to Confidential Health Care. And we did a lot of outreach to organizations, again, beyond women's health. So expanded it to domestic violence, sexual assault organizations, those focused on mental health and substance use disorders, LGBTQ youth, adolescent, and young adult health. And our coalition partners were both individual providers, such as Kim, and also organizational partners, such as community health centers, hospitals, college health centers, school-based groups, and a number of other advocacy-specific organizations. As a coalition, we drafted legislation, which I'll get into the details of in a minute, which would provide a comprehensive approach to improving confidentiality. And I'm just going to show you a lovely graphic that we put together after the bill had passed. But this shows all of the organizations that officially signed on to be a member of the Patch Alliance. And with coalition work, when you have this many organizations signed on, it's really fantastic. I think that, I would say that not every single group that signed on were necessarily an active member of sort of the strategy discussions and whatnot as we were continuing the DOI work and promoting the bill in the State House. But I think it was really helpful to have such a broad, diverse set of organizations behind this, and really helped us build broad support at the State House, as well as get the attention of the health insurers as we were continuing this advocacy. I think Kim is going to talk about the some of the limitations that government employees encountered as we were doing the advocacy.
Great. Thanks, Alyssa. So I think it's important to think about, from the coalition standpoint, I think it's very common that, many of the folks who probably are going to initiate this process are going to be coming from departments of public health or state agencies where they are government employees. And I think one of the challenges that we have with that, and I know this has been recognized in conversations that I've had with folks kind of throughout the country, are limitations from government workers and being able to do lobbying efforts and being able to talk to politicians and try and, drive, policy or legislative process. So recognizing that that is a challenge, I think one of the things that's really important in developing a coalition is recognizing that the more comprehensive or collaborative the coalition is, it does allow for non-government employees to be able to take on some of those roles that, government or state workers, may not be able to have. So I just want to recognize that, there is that limitation, and that where government workers can't necessarily do lobbying, they can do a lot of the education process. They can do a lot of the data collection. They can do story banking. They have a lot of relationships with, again, local and regional departments of public health, where they have access to, patients who may be willing to, submit stories or, come and testify. So it's just something that, this conversation has come up very frequently in conversations that I've had with folks. And so we just wanted to put that out there and just recognize that we do see this as a challenge. And so I think broadening the collaboration of the coalition and including, non-governmental partners can be very beneficial.
Great. So what does the bill, which is now law, what does it actually do? So we as a coalition put together what we think are sort of a comprehensive set of protections. We recognize that this problem is complex and there wasn't going to be sort of one single silver bullet solution to this. So we put together a number of provisions that we think that they're complementary, and that when they work together, they prevent the disclosure of sensitive health information. So the bill, which is now law, would require insurers to send member-level EOBs to each individual insured on the plan as a dependent, rather than to the primary subscriber. So this means that the person's individual name would be sort of addressed on the outside if it's sent in hard copy, as opposed to the name of the subscriber or policyholder. Second, insurers would allow patients to choose their preferred method of receiving EOBs, which would include at an alternate mailing address, which could also be a P.O. box, or through HIPAA-compliant electronic means, which would primarily be through a password-protected website or online portal. Third, EOBs would provide generic information only, such as office visit or medical care, rather than provide more explicit descriptions of the services that were received that could violate confidentiality. Fourth, patients would have the option to opt out of receiving an EOB when no remaining balance exists on a claim. So this means that EOBs could be fully suppressed, not sent at all, for preventive health care services with no cost sharing, such as a birth control visit, STI testing, domestic violence counseling, which are required to be offered with no cost sharing under the Affordable Care Act. And just to take a minute on this particular piece, as I mentioned in the beginning, under ERISA, health plans are required to generate forms when there is cost sharing. So while we would have loved to have the option of having a provision that says, you know, for any particular service, a patient could request that the form not be sent at all, that would conflict with the federal law requirements. So we had to narrow this provision so that it's only in circumstances where an individual doesn't have any cost sharing associated with the health care service. Patients would have to be clearly informed of their options to request confidential means of receiving EOBs, so that would be on the EOB itself. There needs to be disclosure information in health plan privacy documents and on the health plan's websites. There needs to be clear information explaining these new confidentiality protections. And last, our state's Division of Insurance and Department of Public Health would work together to educate providers and patients on these new protections. And I think that we know through talking to some other people in other states who have done this work, but from our lessons learned in other policy work too, that education is a really key component of this. And so unless both providers and patients are sort of fully educated and understand the protections, we know that it won't be implemented effectively and people won't be able to use these protections.
Great, thanks, Alyssa. So now, now that patch is law in Massachusetts, one of the exciting things that we get to work on is looking at how do we educate patients and providers that, now these services are protected. So the table that you have here is part of our education process that we're now starting to develop and roll out. And we want to make sure that we're providing, both patients and providers and consumers, with the information that they need so that they can access these services and even know that they're available. Of course, if we just sort of rely on word of mouth, it could take, quite some time. So one of the things we put together is, this very nice little graph here, or this table. But again, looking at sort of what happens before patch. So, before patch, a patient would really not have a lot of protections on what was written on their explanation of benefit. And now the patient, basically has the right, again, to require that the EOB be sent where they want it to be sent. So that's a huge win. Sensitive services, again, as defined here in the slide, will now be highlighted as more generic terms. So instead of saying family planning or STD testing, it'll say office visit or medical care. Again, that's a simple fix, but it can make a huge difference for patients in being able to seek sensitive or confidential services. The statement, would not be sent, again, if there is no cost sharing and no copay, which I think we all know that under the Affordable Care Act, many of these services are now covered under the Affordable Care Act's prevention services. So oftentimes, things like birth control or routine STI screening generally don't have cost sharing or copay. One thing we were not able to fully remove, and it would have been wonderful, is to have the name of the healthcare provider actually removed. So thinking about it in terms of, for example, if a patient is going to Planned Parenthood, I think that, certainly does key into who the services are being provided by and what types of services. Unfortunately, again, I'm thinking it was because of the ERISA regulations, and Alyssa, you can clarify if that's not correct. We weren't able to entirely remove the healthcare provider name, but again, we can make it more generic. And I just wanted to finish just by saying that what is really important, and in the conversations we had with policyholders or legislative, senators and representatives in Massachusetts, a lot of the concerns really did come from, issues about consent. And so I think it's really important to just highlight, and as we were talking with our politicians, consent laws in Massachusetts are not changing, but access to confidential services are now being provided and protected. And so this is just a quick little infographic that our partners at Planned Parenthood put together. And again, this is part of our education and outreach efforts that we're trying to share. So we can see in this little, story, that Jesse, seeking STD testing or STD services at his local clinic, there's a lot of issues where the EOB, potentially could have created barriers, resulting in Jesse not seeking services, resulting in Jesse, maybe delaying care. Now under Patch, we can see that Jesse has the ability to request that EOB be sent to him or her, regardless of, who is the subscriber of the plan. And so again, this is part of our education outreach that we're trying to use to make it very clear for patients and understanding how this bill really does change, or this law really does change their ability to get sensitive and privacy confidentiality protections.
So moving on to some of the opposition that we encountered, and this opposition started out when we started working on this back with the Division of Insurance, and then some of it continued as we were doing our legislative advocacy. So I think, a really interesting thing to point out about the way that we built our coalition here is that we started out with recommendations, which I outlined before, that the health insurers in the state were opposed to. And through a process of negotiating the language and working with them on the language, and I think putting some political pressure on them, we actually got the health insurers to get on board with us, which is really exciting. So we went from getting them to be opposed to then be neutral to then supportive. So I think that it took some time, but I think that it was a really fruitful use of our time and an important part of sort of what led us to victory here in the state. So I just wanted to preface that because back before the health plans were on board, we did hear sort of the argument from them that the existing protections, which were primarily the HIPAA protections, that those protections in place are sufficient. Well, we know that they aren't sufficient because we were hearing examples from providers across the state and patients of confidentiality being violated, or individuals delaying or foregoing services because of the fear that confidentiality would be violated. And as I said before, we also knew that the health plans were implementing the HIPAA protections inconsistently from plan to plan. So that was a piece of opposition sort of early on when we started working on this that we had to address, and I think we successfully overcame. The next piece is one that Kim just touched on, which is the application to minors. So we heard a lot of concerns, primarily from other advocacy groups in Massachusetts and from some legislators, that this bill is a, quote, secret abortions bill that would just allow minors to access services that they can't access now and hide them from their parents. So we were very clear to develop some educational materials, which we'd be happy to share following the webinar too, which clearly state that under HIPAA, parents can access information about their minor's health care except where state law permits the minor to consent to his or her own care and the minor seeks such care independently. So that means that under our state minor consent laws, a minor that's accessing services under those laws, a parent can't then call the health plan and find out what services their minor has accessed. And so our bill would ensure that this information that should already be protected isn't subsequently inadvertently disclosed to the parent via an EOB. So it's closing that loophole, and as Kim said, it's not existing new it's not creating new state minor consent laws, but it's closing a loophole so that minors can access services that are already protected under the state's existing minor consent laws. And I think once we, this is also sort of a point of contention as we were drafting the bill in terms of how these protections would apply to minors. And I think from our perspective, it was a good balance of sort of middle ground that we could reach, that the protections wouldn't apply to any service that a minor access, but that when minors are accessing services independently already, that information should remain private. Another concern that we heard earlier on from the health insurers was that this would be an administrative burden for them, that putting additional confidentiality mechanisms in place would add to their IT burden, that it would be complicated, that it would take a lot of time. We were able to, I think, get them to a place of being in support by helping them sort of walk through, okay, well, these are the existing protections that you already have in place through HIPAA, and what this is proposing is really to build on those existing confidentiality protections. So if you, as the health plan, already have a way to divert the EOB, this is just saying that EOBs, should not only be diverted, but they should be made available online, and it shouldn't just be for endangerment, but it should be for these other reasons as well. And a lot of health plans were already making certain sensitive healthcare, were already masking certain sensitive healthcare information on the form. So this clarifies what sensitive services should be masked. So it's really building on and strengthening existing protections, and shouldn't be that much more of a burden. Yes, of course, the health plans, some of them have to make changes and some of them are further along than others, but overall, it's not such a huge change. The last piece that we heard some opposition on was around transparency, because I think, in Massachusetts, as I'm sure it's happening in other states, there's a real goal of increasing transparency around healthcare costs and quality, and as Kim said in the beginning, EOBs are a mechanism to promote transparency around healthcare costs. And so we think that these provisions do a good job of balancing the need for privacy and transparency. So by ensuring that the individual who receives the services is getting the statement directly, that ensures that that person understands more themselves, what services they access, how much it costs, etc. In terms of the sensitive healthcare information being masked on the form, there's no prohibition on somebody requesting additional information from their health plan to get more detailed information if they desire that information. We understand that some people may want that information, and again, the bill has that as sort of an automatic masking of sensitive services. But we thought that overall the bill did a good job of balancing the transparency concerns with the need for confidentiality protections. So some of the strategy tips that we thought would be useful to share are first to research the current confidentiality landscape in the state. So that's really, we started out having once we heard that these concerns were rising from patients and providers, we had individual conversations with a number of the private health plans in the state to understand what existing privacy protections they already had in place, what they were doing, et cetera. And I think that again helped us understand what they were doing so that we could, as we were crafting language, be sure that we were building on the work that they were already doing, and making sure that we were not having them create entirely new systems for protecting confidentiality when we could build upon their existing systems. As I mentioned before, building a broad-based coalition was really important in this effort, expanding it. I think, it made sense to start with reproductive health, but expanding the coalition beyond reproductive health providers was really important, both in terms of getting legislative support, but also I think, sometimes when we were thinking about, media strategy, for example, we knew that it would be potentially sensitive to focus just on the reproductive health angle. So we had individuals who were more focused on domestic violence or, be a spokesperson for something. And I think it just helped really raise the level of urgency to help people think about, the vast array of healthcare services that individuals need to access that are potentially sensitive in nature, that are being impacted with a lack of confidentiality protections. As I mentioned before, collaborating with the health insurance plans if possible. So I know that, again, this varies from state to state in terms of the willingness for health plans to sort of come to the table and work with providers and advocates, but I think that if possible, it's good to bring them to the table. It helps to potentially get an ally on your side who would probably be one of the largest and strongest voices of opposition. So I think that really helped our work. Leveraging political support. So we made the strategic decision when we filed the bill to have leaders in the legislature who had actual leadership roles in committees be the lead on this work. We were also able to engage our Attorney General to get her support, and during the bill was filed over a 2-year legislative session, didn't pass that first session, and then passed the second session, and our Attorney General weighed in and provided testimony during the first year, and I think having her weigh in also raised the urgency of this and really gave it some political clout that it didn't have previously. And then the last thing here, which I think is really, really crucial, which Kim touched on also, is documenting the impact of these problems through provider and patient stories. So, through providing testimony when the bill had a hearing, but also all these conversations that we had with the health plans, with the Division of Insurance, with individual legislators, and through raising this through the media, bringing to light the individuals who are being impacted was really powerful. And because because this issue really centers around sensitive healthcare information and confidentiality, it is hard to find individual patients who are willing to come out and share their stories. But we found that that providers could really lend their voices and share those personal stories. Of course, de-identifying any personal information about patients and clients, but that sharing those stories were equally as impactful and really key to getting this law passed. So I'll end with some of the limitations and challenges, which is not to end on a negative note at all, but just to end on where we currently are. So the law passed a few months ago, and it actually goes into effect July 1st. So very, very soon. And so we are already thinking about, as a coalition, as Kim said, how to do education and implementation and make sure that this implementation process is as seamless as possible. So as we've been putting together educational materials and thinking about messaging, we've also come to understand some of the limitations of which plans the law actually applies to, and making sure that individuals across the state understand the limits of the law as well, so that they don't have sort of a false sense of security in terms of what the new law does. So because this change was made under our state insurance law, our state laws only have jurisdiction over fully insured health plans in the state, not under self-insured health plans. So that limits sort of the scope of the health plans that are regulated under this law, and it's different in every state, but in Massachusetts, the fully insured plans are around 50% of the private health care market. So it doesn't seem like a lot, but what we found in Massachusetts is that a lot of the self-insured plans do comply with the same legal protections that are required of the fully insured plans. So we're hoping that happens here too, but we need to make sure that as people are requesting these confidentiality protections, that they understand that if it's a self-insured plan, that these protections would not apply. And so that's also an issue for out-of-state plans. Our state laws can only regulate Massachusetts health plans, not health plans that are an out-of-state plan. So that's another thing to make sure that people understand as they're doing this. And I think also points to the fact that it would be ideal to have a fix happen on a federal level, but in the meantime, states really need to be thinking about what can we use in our own toolbox to address these issues. Educational efforts and outreach, which we've talked about too, but we recognize that there needs to be materials that address all of the audiences that we think need to understand these new protections, so individual patients, providers who will be helping patients, individuals who are sort of the frontline administrative staff in healthcare centers. So we've been thinking about all the audiences, tailoring our materials to different audiences, which types of materials are going to be the most effective in terms of FAQs, fact sheets, brochures and waiting rooms, signage, having an online resource that can provide more information. So we're sort of in the midst of planning our educational campaign and developing materials, and of course a huge undertaking, but a lot of our coalition partners, and it's good to point out too, a lot of the coalition partners who couldn't be as vocal and active on the legislative advocacy piece, they can now really step in and be part of the educational materials development and outreach and dissemination. And then, of course, the implementation and compliance is going to be a huge part of this too. So we have yet to see how exactly it's going to be implemented and how smoothly it's going to go. But we definitely know that we need to be tracking, whether this is working with our state division of insurance to see if they're getting any complaints from individuals, and really encouraging people to let us know if they're hearing that these protections are not working, and also let us know if the protections are working, because unless and until everybody's up to speed, and this includes health insurance, customer service representatives, and others, there could potentially be some confusion. So we're working to monitor the rollout, and also working with the health plans to ensure that their messaging is consistent with ours, so that there's as little confusion as possible as this bill goes into effect, or this law. I keep calling it a bill as this law goes into effect. So I think that is it for us. Kim, unless there's anything else you want to add before we open it up to questions.
No, I think probably in the best interest of the next 15 minutes of time, I can see that there's a whole lot of questions being asked. So, Leandra, I don't know if you want to guide that.
Sure, this is Taryn. I'm happy to. So we're going to start taking some of the questions that have come in through the chat box. If you do have questions and you want to type it into the chat box, please feel free to do so. If you really want to speak it, if you can message Leandra directly and we can unmute you. So the first question we got was from Thomas, and he was asking, did you find any situations in your research where the endangerment clause was ignored and a person was harmed? And he's referencing, this question came up at the beginning when you were talking about the on the repercussions slide.
So I guess I could take that. I mean, I think that yes, I think that, we had several people who testified, directly about how the, current status of the way explanation of benefits were handled in Massachusetts had definitely negatively impacted them. I mean, in terms of from a public health standpoint, do I have numbers to quantify that? I don't. I think it's, more anecdotally and from the story banking and collections that we had. I think that we know, who accesses, for example, family planning clinics and sometimes why. So I think that, to some degree we can quantify some of that information. But, I think when we started doing data collection about, why this bill was important, again, when we think about the, the coalition team, I think you can see that it's very broad in terms of who came to the table. And so I hope that it addresses that question. If it doesn't, let me know.
Great. And then we had a couple of questions as you were going through exactly what Patch said. And so the first one was from Erda, and she was asking, what are examples of sensitive services?
Yeah, that's a great question. So this is Alyssa. I'll take that. So one piece of the law actually requires our Division of Insurance to define exactly which sensitive services have to be masked on the EOB. So the DOI actually has finalized that bulletin. It was a process that engaged the public last summer because as we were still continuing to push legislatively, DOI was still continuing to think about this too. So we actually have the final bulletin that DOI published that we can share with you all, Karen and Leandra, and then maybe you can share that with folks too. But they do sort of list out specifically which services. So I'm probably not going to remember them all. Because they define reproductive health services, mental health use disorder services, HIV/AIDS, services relating to transgender health, LGBT health, missing. Remember?
I'm looking at the actually now.
We can definitely, if you have a person ask a question, you email can email me. This is Alyssa. I can send you the bulletin, which clearly lists all the sensitive services. But overall, we were actually, as advocates, pretty pleased with the services that are included in that list. We did want sort of a catch-all there is any other information that a person deems sensitive to help plan with that it would be too complicated essentially to really implement that on a in the that we were too effective. So we didn't end up having a list. I think in terms of how comprehensive the list is, we were really good with that. I'm happy to share recent service that is on that list.
And I actually have them here, and there are 18, so there are several. So I'll do them really quick. Mental health, substance use, gender transition, testing treatment prevention of STI, testing treatment prevention of HIV, AIDS, Hep B, Hep B, reproductive services, contraceptive services, services, abortion services, pregnancy testing and counseling, any visit assessing sexual assault, pregnancy detention, reproductive health, sexual assault, domestic violence, management, abnormal pap smears, diagnosis and treatment of vaginal infections, and prenatal care. So it's quite a list of 18 of them.
And we can share that. You send that to us. Can we share it when we share the slides?
Great.
So we have another question around that as well. Leila was on a patch what non-sensitive services or non-sensitive services diagnostic restrictions on it.
So there is nothing in law that requires a health plan to map description. So that's so. Is we would advise people to adopt to use one of the other provisions in law. If the person is concerned, different still being revealed, the EOB, that's when they would want to request it from the an alternate mailing address or available only through the online portal. Again, I think there's because there's no single way to do this. We're thinking about it as a complementary provisions that if it didn't work, if one of the provisions didn't work, hopefully a person could look to one of the other protections. I hope that answers the question. And if it was a service where there was no cost sharing associated, the person could request that the form not be sent at all. So that's the second option.
Okay, so the other question, sorry, we noticed there's some people are having scrambled audio concerns, I guess, when we're responding. So we're trying to see if we can sort that out. But in the meantime, we'll continue on. I need to scroll up, Leandra, sorry.
Do you want me to repeat that, or is that okay? I don't know.
That's okay, and we'll send out the list as well.
Yeah.
So we had a question from Heidi asking, how are you able to educate providers on this bill throughout the state? And I know that you mentioned a little bit that you're starting to plan some of that as well with your education efforts and outreach, but I wonder if you could touch on that a little bit.
Sure. So I can start, and Kim, you can add. So we're actually pretty much at the very early stages of planning this. So I think right now we're going to be starting out using our coalition partners. So individual hospitals, health centers, the organizations that. So Jane Doe, which is sort of the umbrella domestic violence organization in the state, and has a bunch of domestic violence shelters sort of as their members, using them and sort of using our existing coalition partners to get the word out and sort of ensuring that information gets to both sort of the front desk staff as well as individual providers. But I'd say that we are, we're sort of still working on the actual substance of the materials and haven't fully fleshed out the plan for dissemination. But I think that it's going to be something that we do need to spend a lot of time thinking about, and it's going to take a lot of time. I know that there are individuals in the coalition who have done this kind of sort of widespread educational campaign before, and I think it's definitely going to take probably a number of years to really have this be something that providers are aware of across the state. But we're going to start off with existing coalition partners and go from there. And I think, just to be frank about sort of resources, we don't have sort of Healthcare for All, nor does any other organization have dedicated funding to do this work right now. So we're all just kind of scrambling to work together to do this work. But I think in an ideal world, we would have dedicated funding, and then it could be sometimes somebody's full-time job to actually, focus on some of the dissemination and outreach that's going to need to happen.
Right, and I think, just to sort of dovetail on that is also looking at, again, thinking back to the coalition and, I think spreading that information. So, looking at who are the partners, who are the folks to be most likely to be impacted, and kind of starting there. And we've been soliciting feedback, so I think that it's going to be a long-term process, but I think we'll get there.
I'll also add really quickly that, as I said before, our Department of Public Health has been a great partner in all of this work, so they were able to do a little bit less in terms of the legislative advocacy, but they've been very much involved in thinking about education. They just convened a series of focus groups with patients and providers around how to best communicate this information, and they, in the office, I forget what they're called, but the Office of Sexual Health in the Department of Public Health, they're thinking about how to get the word out to their healthcare providers. So I think having DPH as a state partner in this is going to really help us with this as well.
Great. We had another question about your partnering for education from Elizabeth. She was asking, are you collaborating with your Massachusetts Insurance Administration on education and outreach to plans and members, and what role does the Insurance Administration have in this effort?
So I'm assuming she means the Division of Insurance. Yeah, I think is what she's referring to. So DOI under the law is supposed to be working with the Department of Public Health on education, and I think that our DOI doesn't do that much in general around educating patients and plan members. What I think we're going to propose to them is that they have, any resources that we have developed either on their website or linked from their website, and they also have the role of, sort of the overseeing the implementation of this, so making sure that the health plans themselves are educating their members, both through the online member websites, through including this information on the EOB documents themselves, through other privacy documents. So I think that, while we do think our Division of Insurance can play a role in education, I think that we're also definitely hoping to work with them in terms of their role as a sort of regulatory oversight agency to make sure that the health plans are also playing an active role in education.
And we had just one follow-up when the people were struggling with their audio. When I asked Leila's question, she said she missed the answer to the issues, but she was mainly wondering if there are some services that can have descriptions on the EOB while sensitive services don't, which could serve as a clue if there was a service listed that did not have a description, if that makes sense. So if you could do a quick recap of that.
Yeah, so I think that absolutely could happen, right? So, and this actually, this kind of came up in the context of what Kim was saying about the provider's name not being removed also. So it could be that, let's say the service itself was masked, but it still says Planned Parenthood. Well, that's indicative that, they potentially access a sensitive service. Or there's some other service that's listed, and this actually came up in the context of domestic violence too. So, someone's, let's say, seeking treatment for an injury that's the result of domestic violence, and sort of a rib injury in and of itself isn't a sensitive service, but it could be sensitive if the abuser finds out that the survivor accessed services to treat that injury. So for those instances where the person doesn't feel that suppressing information or masking information about the sensitive service is sufficient, that's when we would advise that they take advantage of one of the other confidentiality protections, primarily requesting that the form be diverted so that there's no chance that it gets in the wrong hands, or that it's accessible only through the online mechanism, or if there's no cost sharing associated with the claim, that the form not be sent at all. So that's why there's sort of multiple options here, because we think that having an automatic masking of sensitive services is sort of one layer of protection, but that it's important to have these additional layers of protection if that particular protection is not sufficient.
All right, so we're over time by just a minute. So I want to thank Alyssa and Kim for presenting today, and for all of you who participated as well and asked really great and informed questions. For technical assistance around creating language for a similar bill in your state, you can reach out to me, and my email is at the bottom of the slide as well. And I can also connect you with Alyssa and Kim as well. Also, just a quick note, Leandra has posted a brief evaluation survey in the webinar of the chat box. It's only 3 questions. It shouldn't take you long, but it'll help us to inform future webinars. So if you can take just a minute to do that, we'd really appreciate that. Otherwise, thank you all for coming, and thank you for such a great and engaging conversation.